So thank you guys for being here today. Appreciate you all joining us for the ultrasound lecture series for this week. I apologize for being virtual again. We are going to try to get back to in-person very, very soon. But just for some logistical reasons, we've been doing virtual for the last couple of weeks. So, but our intent is to kind of get back into the real person, so we just interact and engage, face to face. But that being said, we're not going to let this deter us. We're going to have some good ultrasound learning today. So today we've invited Dr. Ziad Shaman, who's been a regular in this forum, to present to us about some cardiac ultrasound. So I've asked him to do his diastology lecture. He's given this one in the past, and it's been excellent every time. And so I'm looking forward to having it presented again today.
Thanks, Matt. Glad to see that people are joining in. So the talk today is about preload and diastology. The two go hand in hand. And the objectives are three: to understand the relationship between preload and diastolic function of the heart, to utilize Doppler to measure mitral valve inflow patterns and myocardial tissue relaxation. Those are the two Doppler measures that we will use. I'll show you how to use it. And to apply numeric measurements of LV function to assess diastolic function of the heart. So ventricular emptying and ventricular filling are independent parts of the cardiac cycle. And the cardiac cycle is conceptually divided into systole and diastole, just so that we can allow clinical measurements of disease severity. Systole, I can imagine most people are excited about systole much more than they are excited about diastole. After all, we're all interested in perfusing our organs. That's why, and because the heart pushes the blood forward during systole, that's why we're always excited about this part of the cycle. But diastole is something like logistics support or operations, in which it is as important, it's less glamorous, but it's complicated much more than the frontliner. Actually, diastole is a collection of events that can be divided into 4 stages. Don't worry, those stages make sense. The first one is isovolemic relaxation. After systole ends, the ventricle starts to relax. The volume remains the same, but the pressure in the chamber drops. And after isovolemic relaxation at the very end, the left ventricular pressure falls below that of the left atrium, and the mitral valve opens. That's when stage 2 begins, which is rapid filling. Now, the volume in the LV cavity starts to increase. And because the increase in the volume and drop of pressure below that, it is below the pressure of the left atrium, the ventricle becomes a siphon, and it actually pulls the blood from the left atrium into the left ventricle, rapid filling. Then there's diastasis, stage 3, and diastasis is after the ventricle is filled with blood from the atrium. There is an equalization of pressures, and there is no more flow. This section, diastasis, is our cardiac reserve. This is what we start to eat from when we increase our heart rate. So this is our diastolic, or the whole cycle. This is our reserve, followed by atrial contraction when the P wave comes in. And this is the last stage of diastole, and it causes a second kick of pressure from the atrium to push flow blood into the ventricle. The first section, the isovolemic relaxation, and the second section, rapid filling, are the energy-consuming parts of the whole cycle. So systole does not consume energy, but part of diastole is when energy is consumed in the cardiac cycle. Now, diastolic ventricular function has an important role in clinical manifestations of patients with cardiac conditions. So patients with clinical heart failure who have preserved ejection fraction, the diastolic function is the predominant cause of symptoms. And diastolic dysfunction may also be an early sign of cardiac disease, such as in hypertensive patients, that happens before you start seeing echo evidence of systolic function. Under these circumstances, a small increase in central blood volume or an increase in venous tone and arterial stiffening can cause substantial change in the left atrial pressure. Therefore, it increases the pulmonary venous pressure, which results in pulmonary edema. We all had that event when there's an uncle at dinner on Thanksgiving after they've had a little extra salt, and somebody makes a bad joke or pisses them off, and after they develop a little bit of chest pain, they develop pulmonary edema, and they end up in the emergency room with flash pulmonary edema. This is someone who has diastolic dysfunction, where they can't absorb a little bit extra pressure and volume. In addition to diastolic dysfunction causing symptoms by itself, in patients who have the same ejection fraction but low ejection fraction, so systolic heart failure, those patients might present with a variety of symptoms that are not proportional to the amount of systolic function. This is where diastolic function causes problems beyond what systolic dysfunction causes. And echo techniques now allows us to evaluate the right and the left ventricle diastolic filling patterns, and using the velocity of myocardial motion and the left atrial and right atrial filling pressures. This is the classic view of what volume pressure relationship of the left ventricle looks like in a normal person. So when the volume on the x-axis here is low, the ventricle starts to fill. The pressure doesn't change much until the very end of diastole. And then when systole happens, the pressure suddenly goes up, the volume doesn't change. This is the isovolemic contractility of the ventricle until the aortic valve opens, and now the volume of the ventricle starts to decrease. And eventually at the end of systole, the pressure drops, the volume doesn't change until diastolic filling starts, and now the cycle comes up again. In systolic dysfunction, systolic heart failure, the pressure in the ventricle doesn't change, but the contracts during diastolic filling. But when systole happens, systole cannot be sustained for as high and as long as usual. This curve of pressure volume curve shifts to the right and causes the contractility to end early. So this is systolic dysfunction of the LV. Compare this to diastolic dysfunction of the LV, when the pressure needed to cause volume to increase in the ventricle during diastole causes the left ventricular end diastolic pressure to be high. And this is how the area of this chamber is the cardiac function, represents the cardiac function, becomes smaller, because now you have to achieve much higher pressure to fill up the ventricle to open it up for the next cardiac contractility. So the first step in assessing diastolic dysfunction of the LV is to assess systolic function of the LV. Then, because in diastolic dysfunction, LV filling pressure is, in effect, the left atrial pressure. That's where the blood goes from the left atrium to the left ventricle. And because the left atrium is thin-walled and low-pressure structure, and is at risk of dilation, the second step of evaluating diastolic dysfunction is to look at the RV size. The left atrial size, not LA size. Then finally, to assess diastolic dysfunction, I'll discuss two major items that are an indirect assessment of diastole. That is the movement of the left ventricle during diastole, so tissue Doppler, and the second one is the mitral inflow Doppler velocity pattern. So these are if you've heard of them, the A and the E waves, the E and A waves. Now you might be having a little bit of chest pain, thinking this is going to be complicated. Don't worry, it's going to be step by step, and it's going to make sense throughout. It's normal for a man your age to have chest pain when he drips hot melted pizza cheese on his shirt. Okay. I thought that was funny. So first, systolic function. The general rule is impaired systolic function excludes normal diastole. You don't get to systolic dysfunction without having diastolic dysfunction. So your usual approach to measuring systolic function is all of these things. Most famous is eyeballing, probably, but you can use fractional shortening when you're looking at parasternal short axis using M mode. You can use fractional area change also in short axis, but you need to measure the area. These are the normal ranges. You can use planimetry, which is Simpson's method of summation of disks. You can use 3D volumetry, again, eyeballing, or you can use MAPC, which is an easy measure using, but you have to use an epical 4-chamber view. You can use some other complicated things like contractility, delta pressure, and over delta time, or speckle tracking, echo, which is needs special software. You can also measure the cardiac output. Remember, it's not just the ejection fraction that determines systolic function. You can have a low ejection fraction in someone who has a normal cardiac output, or you can have a person who has a very high ejection fraction but a low cardiac output. So cardiac output you can use if you want to use the LVOT area and LVOT velocity time integration. Just a reminder here that the equation can be simplified to 3 times heart rate times VTI, giving you cardiac output. And for majority of the cases that don't have valvular or anatomical problems, an LVOT VTI of more than 20 results in a calculating, most of the time in calculating a normal cardiac output. The second step after you assess the systolic function is to assess the left atrium. An enlarged left atrial volume excludes normal diastole. Now, this is not an absolute statement. In mitral valve disease, for example, this does not work. But if somebody has normal structural heart and normal vasculature, if the left atrium is enlarged, then you cannot exclude normal diastole. But a normal left atrium most of the time will exclude diastolic disease. So the index here that is used, referred to, is the left atrial volume divided by body surface area. So it's the left ventricular volume, left atrial volume index. And that is measured by, at the start of diastole, so about 2 frames before the valve opens, in apical 4 and then in apical 2. The normal range, the normal pressure, the normal volume should be less than 29 milliliters. If you go up all the way to 40, then this indicates severe dilation of the left atrium. Now, if you notice, 34 is the middle between 28 and 40. So this is the cutoff that is used in assessing diastolic dysfunction. And finally, the third step, which we're going to spend most of the time on, is measuring the LV inflow parameters and also the LV tissue movement. So to measure the LV ventricular inflow, which tells you how fast the blood is flowing from the left atrium to the left ventricle at early flow, early filling in diastole, and later when the atrial kick happens with atrial contractility, as usually named the A wave, you want to use pulse wave Doppler. You put the sample sample volume right at the leaflet, the tips of the mitral valve leaflet, and you run this. After you run this, you're going to get an early flow that's coming towards you, and then a late flow, which is the atrial kick that's also going to come towards you. So it's going to be above the baseline. The envelope is going to be empty. You're only gonna trace the outside of the envelope, and that's the characteristic of pulse wave Doppler, because you don't want to measure the flow throughout the whole distance here. You only want to measure the flow from the atrium to the ventricle. This is affected by age, loading conditions, pulmonary regurgitation, a few other things, but these are the major factors. Once you run the pulse wave Doppler, you're going to get these 2 waves, the E wave and the A wave. They're going to be separated by diastasis phase when there is nothing happening in the ventricle. And if you run in EKG with it, it's going to happen. The E wave is going to start right after the T wave, and the A wave is going to start right at the peak of the P wave. The picture is going to look like this. Now, again, pulse wave Doppler, sample volume at the tips of the leaflet. The envelopes that will show up are going to be empty, part of pulse wave Doppler. And this is going to be the E wave, and this is going to be the A wave. Now, of course, there is an operator-dependent depth determination that you're going to decide where the sample volume is going to sit. And remember, with pulse wave Doppler and color Doppler, you're going to be limited by the pulse repetition frequency. I'm saying this because aliasing can cause a problem if the flow is faster than you think, if you've set the Nyquist limit incorrectly. So I'll show you what I saw at the Cleveland Great Lakes Science Center. They had a water faucet that was dripping water down, and this is under normal light. As soon as you turn on the strobe light that they had in there, you can now distinguish the drops as separate, and you can see them going along gravity because the strobe light frequency is faster than the frequency of the drops falling. But as soon as you can, as you dial, you can dial the strobe light frequency and slow it down. You can see how aliasing happens. The drops that at the start were going downwards because the strobe light frequency was faster than the rate of the drops. They start moving up as you change the frequency by which you're observing the event. So I put this whole slide. I was very much happy to see this experiment at the Great Lakes Science Center. I thought this definitely fits with any talk that describes aliasing. So the drops, of course, aren't going up. It's just the strobe light is much slower now. So you don't have a clear understanding of which way the flow is going. Okay. On the Philips, the pulse wave Doppler button is here. And what you're going to see after you activate it is the following. You're not going to see all of these. These are the pressure waveforms from the left atrium, from the left ventricle, from the aorta, and from the left atrium. Now, this is systole, which we're not going to focus on. We're going to focus on diastole, which is this area here. The pressure is going to be different. The difference in pressure between the atrium, which is the lighter color line on top, and the ventricle, which is the darker color line on the bottom, the difference in pressure creates flow. The flow is going to happen as soon as isovolumic relaxation ends and early filling begins. It's going to fill up. This difference in pressure in this area is going to create the E wave, and then you're going to have an isovolumic and a diastatic state where there isn't any flow, and then you're going to have the atrial kick, increasing the pressure in the atrium above that, the pressure higher than the pressure in the ventricle, which is going to create flow that's going to come towards you. So a normal E wave velocity. This is the E wave, the first of the two. This is A wave. Sorry, A wave. So this is an E, this is an A. A normal E velocity in healthy young individuals is about 1 meter per second or 100 centimeters per second. With an A wave velocity, which is the atrial velocity, flow velocity of 0.2 to 0.4 meters per second, so 20 to 40 centimeters per second. And this reflects the normal small contribution of the atrium relative to the LV, all of the LV diastolic filling. With age, there's a gradual reduction in the E velocity, and this will result in a change in the ratio between the E and the A. The ratio is going to change from more than 1 in young individuals, from 1 to 2 in young individuals, to 1 at around 50 or 60 years of age, to less than 1 in older individuals. So this is the biggest thing that you have to account for when you're doing diastolic functions, probably the age of the patient. As people age, and as people develop impaired relaxation, let's say from ischemia, when there hasn't been any adjustment, any correction from the body or from the ventricle becoming stiffening up, during diastolic grade 1 diastolic dysfunction, which is impaired relaxation, you're going to have a decrease in diastolic relaxation speed, as well as decrease in elastic recoil. And this makes the LV pressure drop slower. Subsequently, it takes a little bit of time before the pressure in the LV becomes equal to that of the left atrium. Thus, the isovolemic ventricular relaxation, which is the IVRT, is prolonged. So it goes to more than 90 seconds. So I'm throwing out a few numbers, but the ones that you're going to focus on are the E and the A. But remember, the isovolemic relaxation time is going to slow as expected. Because of the decreased relaxation of the left ventricle, filling occurs at a slower velocity, so the E wave is going to drop, and the mitral E velocity decreases while the A velocity is increased, because there will be more blood in the atrium to be kicked in when the atrial contractility happens. You will also have a deceleration slope that's going to be more than 160 milliseconds. So I'll show you this. So impaired relaxation, this is normal findings in the mitral inflow. The E is taller than the A. With impaired relaxation, E drops, A increases. The ratio becomes less than 1, and there's deceleration time that prolongs, and the isovolemic relaxation time becomes more than 90 milliseconds. Now, when the situation becomes extreme and the ventricle has had time to develop fibrous tissue and collagen deposits this is when the ventricle loses its compliance. I'm skipping grade 2 for a second. We'll come back to that next. The increase in the left atrial pressure results, because this is the compensation that we develop to overcome the stiffened ventricle, the increase in left atrial pressure. This results in faster opening of the mitral valve and subsequent shortening of the interventricular relaxation time. The high left atrial pressure causes an increase in the initial E peak, the initial transmitral gradient, and because the ventricle is not compliant, the early diastolic filling happens faster, but with higher pressure, faster in time, but smaller in volume. You're not going to measure the volume with diastole, but the ventricle is going to look small. And the atrial contractility results in a small A wave compared to normal, and it's going to be shortened in duration because the ventricle is so stiff it cannot accommodate the atrial kick the way it usually does. So a restrictive filling pattern is what results. The mitral inflow velocities are, there will be an increase in E velocity. There is a decrease in A velocity. The ratio becomes higher than 2, more than normal, which is 1 to 2. And the deceleration time decreases back relative to grade 1 diastolic dysfunction. So again, you have the graphic here. You have the E wave much taller, the A wave much smaller. The ratio is more than 2. Deceleration time drops and interventricular relaxation time drops. In between grade 1 and grade 2, you have some compensation before the ventricle has become stiffened. So in grade 2, things can look absolutely normal just from measuring flows through the mitral valve. It's a transition period from an impaired relaxation to a restricted filling pattern. As the name indicates, the flows resemble normal filling. E to A ratio and deceleration time are normal. The filling pattern is the result of an increased, although it doesn't happen because the ventricle is relaxed, it happens because there's an increased left atrial pressure superimposed on a relaxation abnormality. So in this case, the left atrial pressure increase is going to result in a left atrial volume increase. And that's the change that's going to clue you to a pseudo normalization, in addition to measuring the tissue Doppler parameters, which we're going to go over next. So pseudo normal, the waveforms look normal, but there's an increased velocity. E velocity increases relative to impaired relaxation back to normal. A velocity decreases compared to impaired relaxation back to normal. E to A ratio is 1 to 2. The deceleration time and relaxation in isovolumic relaxation time are both normal. So how can you distinguish normal from pseudo-normal other than looking at the left atrium? Is by using tissue Doppler. And tissue Doppler is going to help you measure the way the ventricle moves. So it measures the longitudinal. You do your measurement of the tissue of the ventricle in a longitudinal axis next to where the mitral annulus inserts either into the septum or into the free wall. And the tissue Doppler will measure this velocity, and we're going to call it E prime and A prime. We're going to focus and use E prime more than A prime, although they both are used in different circumstances. But the one we're going to focus on is E prime. So early filling movement of the tissue. The reason this helps is because E is dependent. So flow is dependent on loading from the atrium against the ventricle, and also on the left ventricular relaxation. But the movement of the mitral annulus, the velocity of the mitral annulus movement, reflects only relaxation. So tissue Doppler can give you this, and if you use E over E prime, you're going to cancel out relaxation, and you're going to end up with measurement of really the loading condition of the LV. That is the left atrial pressure. So E over E prime approximates left atrial pressure. How are we going to do this? We're going to change the frequency and the amplitude of the sound wave that we're going to listen to. So conventional Doppler, you can think of it as listening to high frequency and low amplitude signals from fast moving blood cells. So like listening to a hummingbird. We're going to switch the parameters, and we're going to listen using tissue Doppler interrogation, or TDI. The same principle as Doppler, but we're going to listen to high amplitude, low frequency signals, as if we are listening to an elephant moving or making sound. So high amplitude, very low frequency. Tissue Doppler is used that way to assess motion and speed of the movement. So you hit TDI, you're going to listen to low frequency, high amplitude. The ventricular chambers are going to be empty because you're not going to detect any motion that is low frequency, that is high frequency and low amplitude. So everything is going to look empty. But the wall of the ventricle is going to have this psychedelic kind of picture color. Again, you're going to measure only parallel to your interrogation beam, and you're going to try to figure out which direction the ventricle tissue is moving following the same rules as of regular Doppler. Coming towards you is going to be red, going away from you is going to be blue. Now, notice that this does not tell you the difference between passive and active motion of the ventricle. So if the ventricle is shaking in place because there is pericardial effusion, or because your hand is moving, you will still see color changes. Tissue Doppler is not going to be able to distinguish that from actual contractility. You're going to use color Doppler to decide where the walls are. You're going to put your sample volume again, either at the point where the mitral valve inserts into the septum or where the mitral valve inserts into the free wall, and you hit tissue Doppler again, and you're going to get signal that looks like this. So where E prime and A prime are going away from you. So as the ventricle relaxes, the ventricle elongates, and this tissue is going to move downwards or deeper relative to where you are. So the signal is going to be away from you. Again, tissue Doppler is here next to pulse wave Doppler. And you're going to put your sample volume on the point of insertion. This one is not exactly right. The sample volume should be at the point of insertion of the valve into the free wall or into the septum. And the signal that you're looking for is going away from you. So here's E, and here is A prime and A prime. So again, why this works is because the determinants of E of flow from the atrium to the ventricle depends on LV filling pressure and LV relaxation. LV filling pressure is the left atrial pressure, while the determinants of E prime is only LV relaxation. So if you divide the two, you're going to cancel out LV relaxation, and you're going to approximate the LV filling pressure. And an LV filling pressure that is less than 8 is considered normal. A pressure that's more than 15 is considered high, and there is always a gray zone of 8 to 15. And this is important to distinguish between pseudo-normal and normal LV mitral valve inflow patterns. So E over E prime, again, reflects the loading condition of the LV. It's the best parameter to estimate the left atrial pressure. And actually, there's an equation you can use, which is this one, 1.24 or 1.25 of E over E prime plus almost 2 to predict the pulmonary capillary wedge pressure or pulmonary artery occlusion pressure. So this is where we're going to use it. We're going to look at the tissue Doppler parameters where the waveform is going away from you. And we're going to compare E over E prime to try to distinguish what's happening in the ventricle. For a pseudo-normal, the E over E prime is not going to be normal. It's going to be something abnormal in the gray zone or higher. While in a normal person, the E over E prime is going to be less than 8. So you can think of the pulmonary artery wedge pressure, for example, and say 1.25 of 8 is 12, plus 2 is 14. And 14 is actually a normal, an upper limit of normal wedge pressure when you're looking at pulmonary wedge pressure. While a number that's more than 15, or let's say 16, 1.25, 16 is 20 plus 2 is 22. So that fits. This is a high pulmonary capillary wedge pressure. And this one is somewhere not normal, so pseudo-normal. What your interest, although, might not be, does the person have diastolic dysfunction? When you're seeing them in the emergency room and you're trying to figure out, is this congestion because of diastolic dysfunction? Your interest might be, is the pulmonary congestion because of increased left atrial pressure? So you can use these two kind of flow charts to tell you how to distinguish. If you have someone with preserved left ventricular ejection fraction, you go straight to E over E prime, because you're trying to directly estimate the left atrial filling pressure. If the number is less than 8, you're going to say LA left atrial pressure is normal. If it's more than 15, you're going to see this is high. Now, if the pressure measurement or the pressure estimate here of E over E prime is in the gray zone, 8 to 15, you have to look at the left atrium. Most of the time, you're going to eyeball the left atrium after you've seen a few. But if you want to do the measurement, the cutoff of 34 mils per square meter, so the index is normal. But if the number of is more than 34, then that indicates increased left atrial pressure. For someone with an impaired LV EF, the ejection fraction is low. That's someone who has systolic dysfunction. Instead of going to E over E prime, because most of the time you're going to have some increase in left atrial pressure, you're going to go to E over A. And E over A, if the number is less than 1, then that's going to tell you, and the E wave is less than 50 speed, that's going to tell you the left atrial pressure is normal. There's no increase in flow going from the atrium to the ventricle. Now, this is someone who already has impaired dysfunction, who might already have a type 1 diastolic dysfunction, but the left atrium is not, the pressure is not high yet. If the pressure is, if the E over A is already more than 2, this is someone who already has left atrial pressure increase, because this is a type 3 diastolic dysfunction, grade 3 diastolic dysfunction. If you're in the gray zone, where the E over A is 1 to 2, or the E over A is less than 1, but the E speed is more than 50, now you do your E over E prime. And if the E over E prime is still low, then the left atrial pressure is fine. If the E over E prime is more than 15, then you go to left atrial pressure. And you might ask, why not go straight to E over E prime? You can, but most of the time, if you're using one modality, you want to do things quickly, you're going to do pulse wave Doppler at the mitral valve inflow, and that's it. You're not going to go to tissue Doppler. And you don't have to, unless the E over A is in the gray zone, or it's low, but the speed of emptying is fast, early emptying. This is not the whole story. There are other things, and I'm not going to go over those in detail, but I just want to point them out on those two flow charts. In patients with left ventricular ejection fraction that is normal, an average E over E prime of more than 14, if you have 2 of these 4 to be true, then you do have diastolic dysfunction. If you have less than 2 of these, so only 1 is true, then you have normal diastolic dysfunction. And if you have 2 exactly out of 4, then you are in the indeterminate range. And those parameters are, as you expect, the E over E prime, septal E velocity, this is added, of less than 7, where the mitral valve attaches to the septum, or if it's less than 10, less than 7 and less than 10, if you're measuring at the point where the mitral valve attaches to the lateral wall, you expect the motion to be faster at the lateral wall. You can measure the tricuspid valve regurgitant velocity, and if it's high, then that's abnormal. And left atrial volume index, again, of more than 34. If you have only 1 of these to be true or less, then you have normal diastolic dysfunction. And again, in the when you're measuring at the mitral valve inflow, if the E over A is let's say less than 1, it's the actual number is 0.8 or less, and the E velocity is less than 50, you have normal left atrial pressure. If the inflow parameters give you an E over A of more than 2, you have increased left atrial pressure. But if you have, if you're in the intermediate zone, then you have 3 criteria to go by, and that is the average E over E prime of more than 14. Again, the tricuspid valve, now you're looking at the right side, tricuspid valve regurgitant velocity of more than 2.8, predicting increased pulmonary artery pressure. Because the pulmonary artery pressure predicts the flow on the right side also, because the LVE, the left atrial diastolic pressure, is the wedge pressure. And the left atrial index, again. If you have 2 of 3 or 3 of 3 negative, then you're safe. If you have 2 of 3 or 3 of 3 positive, then you have increased left atrial pressure. If you're in between, you might not be able to determine if you have 1 positive and 1 negative, and only 2 criteria are available. Okay, So this is the table that has all of the normal values. If you so want to take a snapshot of this to save it for later, feel free. I don't memorize this. I keep it handy. But what I usually keep handy is this graph, because it gives me the flow pattern image-wise and the numbers that I really need to know. So to remember E and A, I came up with a way to make it fun and kind of hopefully easy to recall. So imagine E stands for evaluation and A stands for an admission. In normal conditions, you in the emergency room, you're going to evaluate many more patients than you're going to admit. You might evaluate 2 for 1 admission, so that you probably do more evaluations than admissions anyway. But imagine an E and A, usually evaluations are higher than admissions. Now imagine a situation where you have a daunting load. So post St. Patrick's Day, and you have 3 people working in the emergency room. 1 is an intern, and 1 is a resident, and 1 is the attending. The intern probably is going to have their evaluations slowed down because just there's a sheer volume of patients that are coming in. The intern cannot relax, so relaxation slows down. And because they are worried and their evaluations are slowing down and they can't relax, maybe they will admit a higher proportion of people that they're going to evaluate. So evaluations are less than usual, and admissions are higher than usual. Now, imagine the resident who is a 2nd or 3rd year who can evaluate a lot more patients. They're not bothered by the load of patients that are coming in, and they will admit appropriately less number of patients than the ones they're going to evaluate. For an outsider, the situation is going to look normal, but it's not normal. It's pseudo-normal. There are a lot more patients coming in through the door, but a resident can make the situation look normal. Now, an attending, hopefully, can see a lot more patients much faster with actually a faster relaxation time because they're used to this nonsense post St. Patrick's Day, and their admissions are actually might be even lower than a normal day because everybody coming in with concussion or with withdrawal is going to get better in the emergency room and not going to need to be admitted. So now you have an E to A ratio that's much higher than normal. Evaluations are much more than admissions. So hopefully this is an easy way and didn't make it too complicated. So I'll go over 4 cases and see if our impression of the situation works here. I would like people to kind of point in the chat what they think this case is. It's someone with some chronic medical condition comes in with dyspnea, and you realize that they have pulmonary congestion. You get these parameters. You don't get much more of the history. You have the early filling, late filling, and the E prime down here. You don't see the A prime at all. So you have low ejection fraction to start with, and an E to A that is more than 2, high, an E prime, an E velocity that's fast. Remember, 100 is normal. This is still okay. An E prime that's much slower than it should. So relaxation is bad, but E to A is high because the speed of flow is high. An E to E prime ratio that's high. 33 is very high, more than 16. I get 1 answer, maybe 1 more to which pattern you think this is. Very nice. So we have 2 people saying restriction. It is the case of someone with amyloidosis. Imagine this person has had so much deposits in the ventricle. The ventricle is too stiff. The atrium, though, has actually the pressure in the atrium has increased so much that the velocity of flow from the atrium to the ventricle is fast, but the ventricle doesn't move. And the fill ends quickly. It doesn't mean you fill up the ventricle with a lot of blood. You just fill up the small amount of blood very quickly. And the atrial kick is faced with very high resistance. So A is a smaller way. All right. Second case is a 68-year-old female who has hypertension and comes in with just a little bit of dyspnea, as usual. Everybody's going to show up with dyspnea. So her ejection fraction is normal. Her E to A is lower than 1. The E prime is a little bit high or normal. And the E to E prime is pretty much okay. I mean, we said 8 is normal. So she's still in the normal range. Less than 8 is normal. So she's still in the normal range. The flow pattern might be telling. The deceleration time is so slow that there isn't any diastasis. It's very similar to this area here. So any takers? All right, impaired relaxation. Very good. So impaired relaxation is the case here. Someone who has hypertensive LV hypertrophy. The event hasn't happened. The hypertension hasn't been there for a long time. So this is just impaired relaxation. The person hasn't had enough time to increase the left atrial pressure to cause pseudonormalization yet. Pseudonormalization. Okay. And case 3 is the same lady coming in 3 months later. So you can imagine what's happened to her. Was the hypertension treated or not? Maybe she was prescribed the right drugs, but I can tell you right from the E to E prime that this person didn't take their antihypertensives well. The ejection fraction is still normal. The E over A looks normal. The E prime is a little slow. The ventricle isn't relaxing fast enough. So, but what's really telling is E over E prime. Gives me a number that's high. Maybe it's in, you might say it's still in the gray zone if it's less than 15 is the cutoff, but it's 8 to 15, sure. So this fits someone who has become pseudonormal. They started off with impaired relaxation and they had enough time to increase their atrial pressure. Therefore, the flow has started to look normal, but the relaxation is not normal. Okay. And finally, normal EF, E to A, 20, that's 1.5, right smack in the middle of normal. Is this normal or pseudonormal? That's the question. If it's a 23-year-old lady who comes in with a panic attack and you're worried if she does have actually an increased left atrial pressure, and that's why she's dyspneic, or you get an X-ray and you can't really tell from the X-ray because it might be poor quality or limited by body habitus, you can look at the E over E prime in this situation. Normal ejection fraction with a normal E to A tells you this is either normal or pseudonormal. E prime looks like the movement of the ventricle is good. It relaxes pretty quickly. And E over E prime is in the normal range, less than 8. So this is someone who doesn't have diastolic dysfunction. Okay, so in summary, we have relaxation and preload. Both affect diastolic function of the ventricle. That's why you have to use multiple evaluation methods. You first assess the left ventricular systolic function, then you assess the left atrial size, and you look at the pulse wave Doppler at the mitral valve inflow between the mitral valve leaflets to measure E and A, early relaxation and atrial kick. You get the E to A ratio, and you can use tissue Doppler imaging at the mitral valve insertion to the septum or to the free wall for an E over E prime measurement. These numbers that I mentioned are for the free wall E prime. Pattern recognition is important, and clinical correlation as always. And here is your summary slide of the numbers that you want to remember immediately, if you want to remember anything. Impaired systole excludes normal diastole. Left atrial enlargement excludes normal diastole. In parentheses, that means it's not always true, but most of the time, according to multiple other parameters. Normal A to A is 1 to 2. Impaired relaxation will make the E slower, so the ratio becomes less than 1. When the left atrial pressure builds up, E over A becomes normal or pseudo-normal. And when the ventricle finally stiffens, the fill pattern becomes restrictive and E to A becomes more than 2. To distinguish between normal and pseudo-normal, use E over E prime. Normal number is less than 8. If you want to venture out and use it to predict the pulmonary capillary wedge pressure, the equation is 1 1/4 E over E prime plus 2. And that will be an easy thing to remember, actually. 1 1/4 E over E prime plus 2.